Ms Cartwright.
My lady, please could Baroness Harding be sworn?
Solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth, and nothing but the truth.
Could you please give the inquiry your full name?
Baroness Dido Harding.
Thank you. Baroness Harding, you've provided a witness statement to the inquiry dated the 9th of April of this year. Could we please turn to page 49 within that statement, where you confirm that the statement is true to the best of your knowledge and belief? And can I ask you to confirm, it is the statement true to the best of your knowledge and belief?
It is indeed.
Thank you. Can we then please start with identifying your relevant background and experience, which is detailed within the statement? Plainly, the significant aspect of the evidence that we will deal with together is your role following appointment on the 7th of May of 2020 as the Executive Chair of NHS Test and Trace. But can we please then identify your career history? It's right, isn't it, from 2010 onwards you had a career in telecoms?
That's correct.
And before that, between 1988 to 2010, you also had a career in retail.
Correct.
And do you want to give some relevant context as to those careers and skills, to contextualise then skills that you deployed when you were Chief Executive in NHS Test and Trace?
So if you think of the skills that you needed to grow NHS Test and Trace, you needed people leadership experience, and I'd worked in very large organisations in both the public and the private sector, scaling them particularly in the private sector. You needed understanding of healthcare and public service, and I'd been involved in NHS improvement. You needed retail and logistics experience because testing and tracing was fundamentally an enormous logistics exercise. And you also needed experience of digitally enabled, large-scale citizen or consumer services, which I'd done a lot of in telecoms as well as in retail.
Thank you. And now you've identified your role with as Chair of NHS Improvement. And I think it's right, isn't it, that you had that role from October of 2017 and you held the role until October of 2021.
That's correct.
You were also, from 18th of August 2020, which we'll come on briefly to deal with in your evidence, Interim Executive of the National Institute for Health Protection, which was a body that then became part of UKHSA. Is that
Yes,
correct?
I was Interim Executive Chair.
Thank you. And you were also Chair of Genomics England from 2019 till October of 2020.
Yes, that's correct.
Thank you. And I think more broadly, you're a member of the House of Lords and have been so since 2014.
That's right.
Thank you. Now, I know one of the things that you particularly want to deal with at the outset is what's dealt with at your paragraph 1.4 at page 2, where you wish to express your condolences to those who lost loved ones in the pandemic. And so if we could just display paragraph 1.4, please. Baroness Harding, do you want to address that aspect first of all, please?
Yes, just before we get into the detail, my lady, I just wanted to express my sincere condolences to everyone who lost loved ones and who suffered because of the pandemic. And just to reiterate how important I think this inquiry is, that we really learn the lessons of what happened.
Thank you. Now, can we then please start with your appointment, please, as the Chief Executive of NHS Test and Trace? And can we move to paragraph 3.1, please, on page 5? You detail that on the 5th of May of 2020, the then Prime Minister, Mr Johnson, called you and asked you to lead what was then called the Test and Trace Task Force. You say, from the conversation I understood that the role was to be an operational as opposed to a policy or political one, and involve the rapid expansion of the infrastructure to facilitate widespread testing for COVID-19 and contact tracing, which would produce an essential end-to-end population service, i.e. a service accessible to all the population, and to recruit a permanent leadership team to lead what would be a large organisation. Details you understood that the role would be temporary, and you accepted the position, and your appointment was announced publicly 2 days later on the 7th of May 2020.
Yes, that's correct.
I think it's right, isn't it, and it's well known that there has been a judicial review in 2022 of both the Prime Minister and the Secretary of State for Health and Social Care, brought by the Good Law Project and the Runnymede Trust in relation to a number of appointments, including your appointment both to NHS Test and Trace, and then latterly to the role with the NAHP. But I'm referencing that at this stage because it's right, isn't it? More factual context was given to the lead up to the telephone call from Mr Johnson on the 5th of May within that judicial review. And is it right that the background that's detailed within the judicial review includes essentially that there was a short list of candidates that have been identified to be approached in respect of the ask to be the chief executive, and then the role as to how it was you were then identified as the ultimate candidate and approached by Mr Johnson?
Yes, I don't have any more knowledge than that which any of us would have reading the outcome of the judicial review. So I've read that, and that was the first time I was aware of the detailed process that went on before I received the phone call from the Prime Minister.
Thank you. And so can you give us some idea as of the 5th of May, because we're going to look at the scale of the task that faced you, having said yes to the Prime Minister. Can you perhaps just give a bit more of an idea of when the Prime Minister had that conversation with you the 5th of May, what was really the detail about what was being asked of you and what was required?
So by the 5th of May, the government had already announced the intention to launch a citizen-level mass testing and tracing service. It had already been decided how many contact tracers were needed to do that, and the teams were working flat out to stand that up. Several of the Lighthouse laboratories had already got started, and the team that existed had delivered 100,000 tests at the end of April, which was the first target that the national testing programme had been set by the Secretary of State. So there was the beginnings of what became NHS Test and Trace, with a relatively small team in the Department of Health and Social Care working sort of 20 hours a day, 7 days a week, trying to scale this and launch the service as fast as they possibly could. And the brief that I received from the Prime Minister and from the Chancellor in that first week was to do everything possible to launch and then scale in their words, not mine, world-class testing and tracing service to support the country as lockdown measures were released.
Thank you. Now, you've referenced that the Chancellor was also in that initial meeting. I'm going to deal with it at this stage because one of the reflections you provided and comments for future pandemic planning is the need to essentially have regard to the most vulnerable in society, and their need to be essentially money there to assist with isolation. Was anything said in that initial meeting around that problem in terms of an identified issue that those individuals who perhaps are most vulnerable or most needing were not isolating and not testing because essentially they had to feed their families?
To be honest, in that first meeting, no. At that stage, the brief I was receiving from the Prime Minister and the Chancellor was all about scale. And it became clear to me as I spoke to public health experts and people from local government, from Public Health England, from my colleagues from NHS England, that it was really important to build a service that supported the most vulnerable, but that wasn't in the brief that I initially received at all.
Thank you. Now, it's clear from your statement that is something that became a real concern for you. My summary, if it's inaccurate, please correct me, Baroness Harding. But can you help us then on the timeline, once you were in post and dealing with the issues to scale up testing and contact tracing, when you realised that was a big issue relating to there not being support payments there to assist those most vulnerable to isolate?
For isolation support,
yes.
Specifically. So I think through May and early June, as we work through what makes for a really successful testing and tracing service. It's obvious, and I know others have said this, it's only useful if the service enables people to actually isolate and break the chains of transmission. And through the course of early June, as we got early feedback from people using the service, it became increasingly clear that one of the main reasons people didn't come forward to get a test in the first place, why they didn't come into the system at all, was because they were afraid of the consequences of needing to isolate, both financial and non-financial. So from June onwards, from a purely operational perspective, and my brief was operational, not policy or political, but in order to make the service I was being charged with building more effective, it was clear that one of the biggest levers you could pull would make it easier for people to isolate, that we were only finding a relatively small proportion of the people who had COVID at the time, and we could assess that through comparing with what the ONS survey was telling us the prevalence of the disease was, with the number of people who were testing positive each week. And so all of the economic modelling showed you that the most effective thing you could do was make it easier for people to isolate. And then all of the human lived experience told us the same. So I'm a retailer by training, really, as you've said, and retailers, we go out to our shops and we talk to our customers and we talk to our staff, and they always know what's really happening. So I went out in June, July, August, all the way through, really, and I'd talk to staff in testing sites. I would do virtual listening groups with a variety of different groups of generally unheard, disenfranchised, disenchanted groups in society who didn't feel like the system was working for them. And they all said the same thing, which was that isolation was really hard to do and we weren't doing enough to support them. So I started trying to fight for this in June 2020. And to be honest, my lady, I feel like I still am. And that I think it's one of the most important learnings for this inquiry, that a mass testing and tracing system can have a huge impact in reducing the harm of a pandemic, but it is so important that we support the most vulnerable. They're the most exposed to every infectious disease, and that means you have to put isolation support at the forefront of your testing and tracing system.
Thank you. Baroness Hardy, we'll come back to that issue and topic as we work through the chronology. Can we then please deal with what you've told us about your role being an operational one? Please could we display your paragraph 4.2 at page 7. You tell us that NHS Test and Trace was an operational organisation implementing UK government policy when first created. NHS Test and Trace operated effectively as a new operating directorate of the Department of Health and Social Care with a specific remit as part of the pandemic response. The policy decisions were all taken by ministers, and as indicated above, ministerial accountability for the programme remained with the Secretary of State for Health and Social Care. My role was an operational one. I had to take ministerial policy decisions and the scientific and medical guidance that the Scientific Advisory Group for Emergencies and Chief Medical Officers provided, and then advise ministers as to the best operating system and service to meet those requirements. Following ministerial steers, I was then charged with implementing and running this operating system and service. And so it's clear what you're saying there as to your remit, your role, and plainly it required also input from ministers for decisions you were to make. Is that correct?
Absolutely.
And I think one of the things that we'll come on to as we move through is the limits you had on procurement that was also a fetter on your ability to operate operationally. Is that a fair summary?
At certain times during my tenure, yes.
Thank you. We heard yesterday from Mr. Munn from the Cabinet Office, who effectively said, when asked who was responsible for NHS Test and Trace, that it was you. I'd like to give you an opportunity to respond to that in the context of what we've just looked at by reference to your operational role, please.
Well, I've tried to describe I was operationally accountable for the organisation, but the strategy was set by the government. Policy decisions were therefore made by ministers. The accounting officer was David Williams, the second permanent secretary in the Department of Health and Social Care. It's important I didn't have any spending authority. So although I very much felt accountable for the operational performance and delivery of NHS Test and Trace, I don't think you could say that I was single-handedly responsible and accountable for everything, because it sat, as it properly should do, within the system of ministerial and civil service responsibilities.
Thank you. Can I then please identify with you what already existed, which the inquiry has heard some evidence from? We know that by the time of your appointment in May of 2020, the first 4 Lighthouse laboratories had opened in April of 2020, and the inquiry has heard some evidence about the task force that had put that together, and I think on your appointment was stood down from their role under the operation of the Lighthouse laboratories. Did you have any handover from those teams that had scaled up the first 4 Lighthouse laboratories when you took on the role in May of 2020?
Yes, absolutely. So the senior team who comprised the national testing programme, who had come from variously from the Office of Life Sciences, from the Department of Health, from the military, they transitioned, most of them, the senior leadership transitioned off by the end of May, and we recruited in to replace them. Some stayed throughout the whole duration of the pandemic. So we tried wherever possible to maintain the knowledge that they had built as they'd done that first phase of scaling testing.
Thank you. Now, you've already mentioned that at the time of your appointment, there was these, I call them call centre, well, virtual call centre contact tracers that had already been appointed. But certainly what seems to follow from May onwards, and certainly towards the July of 2020, under the Contain framework, was more input from local resources on contact tracing, and in particular, the directors of public health. We can see that one of those that I think was appointed as part of your team was Mr. Tom Reardon from Leeds City Council. Yeah. And so can you help us in terms of what you did in your role around the central to local and acknowledging or realising the need for more input from the local contact tracers expertise, please?
Yes, so as I said, when that first week I was appointed, I made a number of calls to people that I knew in the NHS and in local government, and I've listed some of them in my statement, and had pretty universal feedback that local authorities were feeling excluded from the plans to scale up contact tracing, and that we needed to make much greater use of their expertise and relationships and capability. So the first weekend I worked with Mark Lloyd, at the time was the chief executive of the Local Government Association, with others, to find a respected local authority chief executive to come into the Test and Trace leadership team, and that was Tom Reardon. And Tom, in turn, recruited a team of mainly ex-local authority chief executives to act as regional coordinators to help us coordinate better with local authorities. And Tom held the pen on developing the Contain framework. So one of the things, my lady, that wasn't in place at the beginning of the pandemic was a clear sort of set of the relative responsibilities between sort of local government, regional government and national government in testing, tracing and isolating. And so Tom worked really hard to set that out and present that for approval to a COVID-0. I think it was approved at some point in June. So it was very clear to Tom and I we needed to get more local. We also had to have scale. So you mentioned the 15,000 odd contact tracers that were being recruited. They were literally being recruited live and trained during that 3-week period from my starting and the service launching. That was a non-trivial, enormous task that was being run by NHS Business Services and Michael Brodie as part of a virtual team with Public Health England. So this was lots of different moving parts, but from the very beginning, I felt that it needed to be, the phrase we used was a team of teams, that you needed both the scale of a national call centre to provide surge capability if you had an outbreak in one part of the country or another. You needed a national data spine. A lot of the contact tracing we all did ourselves when we filled in the information ourselves on the web form. You needed that all to be consistent, but you also really needed the local knowledge and expertise. Just by way of context, when I started, there were 290 trained contact tracers in the Director of Public Health teams and the PHE regional teams in the whole of England. So and we needed 15,000. So you had to have some form of virtual national call centre, but you needed the local expertise as well. And through the course of 2020, we shifted more and more towards that local and national team of teams. Maybe one fact that's not in my statement that probably should have been before is if you look at the budget for contact tracing for the year 2020-2021, we spent £1.8 billion in the local outbreak containment fund, which was all money that went to local authorities for their local contact tracing and isolation support, and we spent 900 million, so roughly half on national contact tracing. So it took time, and with the benefit of hindsight, you'd do it earlier, but we worked really hard from May onwards to get this balance right of local and national working together.
Thank you. And can I ask you, with identifying the budget that was then provided, I think, in the July of 2020 to local authorities, was there any discussion around why there had been the underutilisation of the Directors of Public Health before you had been imposed in the May of 2020?
I think that this is quite a Whitehall disease to not understand how local government works. And I think it actually can be quite a local government disease not to understand how national government works. And so it wasn't discussed.
You to slow down.
Oh, I'm so sorry.
For the stenographer. I'm sorry for interrupting you.
Sorry, I'll try and speak slower. I think that it's quite an institutionalised disease for the national teams not to really understand the strength and benefit that the local teams bring, and vice versa, which is why I think it's so important to have both. So from memory, Tom was widely respected amongst his local authority colleagues, but also widely respected in Whitehall. He'd done a job in what was then the Department for Levelling Up. So he had relationships at both national and local level, and therefore was heard. But I don't think it was something that the discussions had happened before we brought him in.
Thank you. Can we then please move to your paragraph 4.22 on page 16 of your statement? You detail the following. I recruited the majority of the first executive committee of NHS Test and Trace over the first weekend after I was appointed. Whilst the leadership team, mainly comprised of secondees from the Department of Health and Social Care, NHS and Office for Life Sciences, I inherited at the beginning of May 2020, had done an extraordinary job scaling PCR testing to 100,000 a day. They were utterly shattered and did not have the operational experience that was needed to lead NHS Test and Trace to the scale required. Although a small number of the senior team stayed on with NHS Test and Trace, most were exhausted and took leave before returning to their home departments. I therefore set out to bring into NHS Test and Trace experienced, seasoned leaders from the NHS, local government and the private sector. I sourced candidates via headhunters, the chair of the Local Government Association, the Cabinet Secretary and the Deputy Chair and Chief Operating Officer of NHS England. And where it was possible to identify multiple candidates, interviewed them over the weekend and first week, wherever possible, together with the second permanent secretary at the Department of Health and Social Care or NHS Test and Trace's Chief People Officer, once the latter was appointed. The individuals we appointed were either seconded from their permanent organisation or on gardening leave from commercial jobs, and therefore immediately available. I asked them to serve for 3 months initially. This process is obviously not standard for public or private sector recruitment, but was essential given the urgency of the problem at hand. Can I ask you then, in terms of that and also what you go on to deal with, which was essentially after that first 3 months, that again, a number of the staff you lost in the August-September time. And so were the urgent measures that you outlined there necessary because of the absence of planning before you being in the role?
Yes, but I think it's also the reality of a crisis that no matter how well you've planned, you will need to do some form of urgent recruitment for skills that you hadn't thought about before. But the reality was there was no plan for scaling a national level testing and tracing service. So the fact there was nothing at all meant that obviously we were having to start from scratch in recruiting people.
And you say no plan. The evidence the inquiry's heard is as to what was been done to scale up the Lighthouse laboratories. And so can you just contextualise what you say there, that there was no plan still, notwithstanding the existence of the Lighthouse labs?
So I was really referring to January, February, March, that there was no plan before the start of the national testing programme. So the team I inherited were necessarily focused on a very, very short-term objective, which was to stand up the first phase of Lighthouse Labs to get to 100,000 tests. I think within a week of my arriving, the Prime Minister announced the 200,000 test target for the end of the month, and we had a goal of launching the end-to-end testing and tracing service by the end of the month. So the time, it almost seems crazy describing it here now. You had 3 weeks to launch a national citizen service, and the management team for the national testing programme had literally been working all hours that they had. And in my first meeting with them in the first week, most of them told me how they were just about to finish and go back to their home department. And that's no criticism of them at all, my lady. They did an amazing job. But we needed, in literally a matter of hours or days, to have really experienced leaders to tackle this enormous task. And inherently, you could only plan towards that first objective, which was getting the service up and running. My first chief people officer, her primary objective in the 3 months that she was seconded to us was to recruit a permanent leadership team. You couldn't recruit a permanent leadership team over a weekend. You could only recruit people to come in on secondment or free of charge on loan from another government department or from a company, and you couldn't ask them to stay indefinitely. The only way I could persuade great leaders like Tom Reardon to come, Sarah Jane Marsh, who came from Birmingham Women's and Children's NHS Trust, for example, was to promise their respective chairs that I would send them back after 3 months. Some of them stayed longer than that, for which we should all be eternally grateful. But it was an exercise of gentle arm twisting to persuade experienced leaders from across society to come and help.
Thank you. And perhaps this is an appropriate opportunity to ask also, did you receive remuneration for your role as Chief Executive of NHS Test and Trace?
No, though I was executive chair, not that it makes a huge difference, but no, I was paid as the chair of NHS Improvement. I continued to be paid as the chair of NHS Improvement. I took no additional remuneration for Test and Trace.
Thank you. Can we then please move to paragraph 4.29, please? At page 18. Thank you. You detail that once NHS Test and Trace had been launched and it was clear that the service would be required for more than a few months, the then Chief People Officer launched several concerted efforts in the summer of 2020, including a 2-week resourcing sprint in late August and early September to fill vacancies and to recruit civil service staff to replace consultants, especially in management roles, on the basis this would be less expensive and provide greater long-term continuity and therefore be better value for money. This proved extremely difficult to achieve, partly because some of the skill sets were in very short supply across the civil service, e.g. programme management, digital development, and partly because working in NHS Test and Trace was inherently a short-term assignment under enormous scrutiny and pressure, which certainly deterred some candidates. Given the frequently changing course of the pandemic, it was difficult to provide certainty to colleagues for more than a few months. And as the pandemic progressed, this became less and less appealing to those in permanent civil service roles who understandably looked beyond the pandemic. And so can I ask you, in terms of the gap in staffing that certainly you detail in the statement was acute in the third week of August of 2020, can you help as to what accounted for that gap?
So in a crisis, there are two places that government goes to get resources. So the first place is you look to second civil servants from non-crisis departments or functions. So that's the first place. The second place you go is to the military. To use military resources to urgently stand up services that are particularly brilliant at logistics. And NHS Test and Trace and the National Testing Programme had used those two sources in extremis, to the extent that we were using all that we could from the public sector, both civil servants and the military. So you have to then fill the gap with short-term consultants or contractors. And that was how the vaccine task force was stood up. It was how the ventilator challenge was stood up. It was also how the national testing programme was stood up. So when I arrived in May, a substantial proportion of the operating workforce were consultants and contractors. And we recognised from an early stage that, as the statement says, that you want to have more permanent expertise and knowledge, and it will be cheaper to have people in permanent roles. So the work that went into trying to replace temporary consultants with permanent civil servants began in real haste and scale in that summer under the then Chief People Officer, using the full support of the Chief People Officer of the Civil Service and the team in the Cabinet Office. But to be honest, we didn't move the dial at all, because as fast as we recruited permanent civil servants to come in, new tasks were set us, either by the disease or by ministerial decisions because of the disease, to build new services. So as fast as we filled vacancies with permanent staff, we ended up recruiting more consultants, such that by the time I handed over to Jenny Harries, the numbers were not that dissimilar to the way they were in the summer. And I know that she then led similar exercises to replace temporary consulting staff with civil servants.
Your statement identifies volatility in the laboratory workforce, including staff as a factor affecting capacity in September of 2020, which continued into the autumn. Should there have been a more robust approach to recruiting competent and reliable staff in the preceding months of May to September, rather than recruitment to generalist consultants?
I think the thing to remember about people working in the laboratories is that they were working on a shift system 24 hours a day, 7 days a week, and they got COVID too. So when we refer to volatility, it was volatility from absence because of COVID illness and COVID isolation, rather than any lack of capability to do the role. I think that the combined teams of biomedical scientists and students who worked in those laboratories did an extraordinary job. And if anything, one of my concerns I have, my lady, is that it's tempting to assume that because they were temporary, they weren't good. They worked really hard, and they deserve our thanks, I think.
Thank you. Can I ask then, in terms of this shortage of staff in the autumn time, is the lesson for the future then that there needs to be planning and trained and exercised specialists who can rapidly stand up such agencies and recruit relevant competent staff at pace?
Yes, I've been doing lots of thinking around how do you have that surge capability, because it's plainly not economically sensible to have all of these people waiting with nothing to do. And so for both scale testing and contact tracing, working through how you have some form of reserve force. It's almost easier to see in contact tracing, where the local authorities, directors of public health, but also people working in local authorities could easily be a public health reserve force, able to contact trace if needed at scale, just in the same way that we think of military reservists. So I think that's an easier way to think about it. For the setting up of laboratories, clearly you need more specialist expertise. But again, thinking about how do you have more of the sorts of things like the government the government commercial office, we actually did fantastic work, the GCO, a small team of world experts at procurement who were able to be deployed during the pandemic. We should have a similar small team of experts for programme management, a similar small team of experts for digital product design, a similar small team of experts for diagnostic, quality assurance, etc. You could build that sort of capability that could be deployed from existing organisations. And I think that's at the heart of how you have a system that can stand up faster.
Can I just go back? First of all, you mentioned the Reserve Force local public health specialists. You said that you could deploy them as a reserve force who could then scale up. How do you do that with a limited number of public health experts? As you'll appreciate, every time I make a recommendation, I've got to work out how much will it cost.
I understand.
Because I'm not going to get recommendations passed to government strapped for cash unless I can make it cost effective. So how do you have the kind of reserve force you're talking about, and then maybe move on to the project management teams and the other teams? How can you make them able to have the surge capacity but not cost a fortune in ordinary times?
I think you have to use the existing health and social care ecosystem that we have. So we spend 150 billion on our health and care system. So I think we need to think about how we are pandemic prepared in the way that we spend all of our money in health and social care. So, for example, on the laboratory side, if you think about how we have scale pathology labs in the NHS, as opposed to lots of small labs in individual trusts. One of the big differences between Germany and the UK as we went into the pandemic is that Germany had regionalised pathology networks. Lord Patrick Carter actually recommended reducing the number of pathology labs in the NHS from 120 odd to 29, I think, in 2008. But as we went into the pandemic, that still hadn't happened. So if you had a more scalable pathology service, which would actually give better diagnostic capability for the NHS today, that helps with your labs. If you follow the evidence of Lord Bethell on more focus on public health, more focus on prevention, more community services in our approach to health and care, what that will give you, my lady, is a larger team of people who won't be public health experts, but who could do half a day a year's training in contact tracing, so that when their local public health experts need them, they're able to be deployed.
Thank you.
Thank you. Can we display your paragraph 4.31, please, at page 19? You detail that there were occasions on which NHS Test and Trace was instructed by HMT and or the Cabinet Office to reduce operational capacity, and I'm going to move to paragraph 5.11 in a moment, in testing and contact tracing, only for infection rates to rise rapidly, with the consequence that resourcing needed to quickly scale up existing services to meet demand. Further to that, NHS Test and Trace was frequently tasked with building new services within short timeframes, such as testing the whole population of Liverpool and standing up education testing over the Christmas holidays in 2020 to 2021, which required consultants to be brought on and retained. As such, despite sustained efforts to reduce the use of consultants, NHS Test and Trace continues to use substantial numbers of temporary labour and resourcing throughout the pandemic. Can I ask you, you've identified rising infection rates. Could you just give us some clarity to the inquiry about the role of the JBC as a resource that you had from May onwards that helped identify infection rises or things on the horizon, please?
So the Joint Biosecurity Centre was conceived as the data analysis engine for the testing and tracing service. So they took all of the data that came from our test results and contact tracing and used that to provide analysis to the CMO and to ministers to enable them to make decisions on implementing other non-pharmaceutical measures like local lockdowns. So the JBC was a core part of my team because they relied on the wiring, if you like, the data flowing from test and trace, and they played a role in thinking through what questions do you ask someone to fill in when they order their test, so that you get demographic information, for example, to help you understand who might have the disease and whether there are particular pockets. So they needed to be integrated into it. They were the data providers and analysers in the local action committee, the bronze, silver and gold meetings, the silver chaired by the CMO, the gold chaired by the Secretary of State for Health and Social Care. So they were using what Test and Trace, and they used other data from the NHS and other publicly available data sources to provide advice on where and how to combat the disease at a local level.
Thank you. And then can I ask you, informed by that resource and expertise, you referenced rising infection rates. Are you able to assist as to whether the JBC provided intelligence before as to the increase in infections in the community again prior to us going into the second lockdown on the 5th of November of 2020?
Yes, they did. So I think I wasn't obviously there during the first lockdown and the decision where there wasn't the data. But by August 2020, it wasn't perfect, but the JBC were producing sort of daily readouts from the Bronze Committee, weekly readouts for silver and gold. And in the we'd seen in Scotland, when schools go back earlier in the middle of August in Scotland, when schools went back earlier, Scottish infection rates had risen. And as schools came back in that first week in September, you started to see the infection rates rise. And the JBC did highlight that to me, but also through me to the CMO and the Secretary of State. And I think I know others have commented on this, that through September, October and November, it was clear that infection rates were rising. And, it's so easy with the benefit of hindsight, but with the benefit of hindsight, I suspect we all see we should have locked down earlier.
Thank you.
And you've linked the rise in, or may have appeared to some to have linked the rise in infections to the schools going back. But of course, the schools are going back at a time when restrictions were being eased.
And I'm not an epidemiologist, so I need to be very careful. My lawyers keep telling me to stay in lane. And the CMO would be far better placed than I to give you the full answer. What I can say is that it was the JBC's role to present that data. And the head of the JBC, with me sitting beside her, did do exactly that in those early couple of weeks in September to both the Secretary of State and to the Prime Minister.
Thank you. Can I ask you then, perhaps looking earlier in the chronology as well, as to what impact decision-making may have had upon capacity or demand on NHS Test and Trace? Obviously, restrictions were eased, and the original coming out of lockdown was around the June period of time. Was there any feeling equally that had been too soon in terms of then the impact that was having around the demand being placed for tests on NHS Test and Trace?
I mean, as I say, I'm not the expert, so I need to be careful. But I think that through that summer, as a country, we were running hot in terms of the infection rates compared to some other countries that had taken longer to come out of lockdown. And a testing and tracing service is going to be operationally more effective with lower infection rates. So there's no doubt that it made it harder. But that's a political judgment, not one for me.
Now, I promised that we'd go to your 5.11, but can we move first of all to 5.10 on page 20, please? You detail that, for example, NHS Test and Trace faced various difficulties in obtaining HMT and Cabinet Office approval for Lighthouse laboratories in the summer of 2020. And this meant that the approvals process for the expansion of the Lighthouse network took far longer than it should have in the circumstances. Had NHS Test and Trace had greater delegated procurement authority during this time, this would likely have reduced the capacity issues we experienced in the autumn. It was these frustrations which led to the substantial delegated authority to directly approve spending on PCR and lateral flow device tests and award contracts up to 150 million that was agreed with the Prime Minister and HMT from 22nd of September 2020. Now, I think there's some underpinning material that details the problems around the continuation of the scaling up the Lighthouse laboratories. But can I ask you, can we display, please, just briefly to capture the state of play in May, I&Q, please, 587456. Thank you. And we've looked at this map on a number of occasions with individuals, and we can see that the first 4 Lighthouse laboratories were established in the April. But then it was not until October of 2020 that the Newport Lighthouse Laboratory was operational. November for Charnwood, and then it took until the March of 2021 for the further laboratories at Plymouth, Brantsbridge and Baltic Park to then come online, before finally the Rosalind Franklin Laboratory in June of 2021. So April to then October before Newport. And so can you assist, did the procurement issues that you've identified result in what seems to be a big gap and a slowing down of the scaling up of the Lighthouse Laboratory network?
Yes, I think it did. And just to give a bit of context, if you go back to how we all felt as we came out of that first lockdown, it was very tempting to believe that COVID was beat and the world was getting back to normal. And I think that's what we experienced in government procurement decision-making. There were substantial voices wanting it to return to pre-pandemic normal procurement processes, which would have been months, if not years, before you would procure at this scale. And that definitely slowed down the building of the next phase of Lighthouse laboratories. It also slowed down the scaling of existing Lighthouse laboratories. So the path to 500,000 tests a day for the end of October that we were tasked with required us to expand capacity in the existing labs as well, not just the Lighthouse labs. It required the NHS and PHE labs to expand and other labs too. The business case for all of that expansion took far too long to get approved through June and July. Some of that may well have been due to inexperience in my own teams. It was the first time we'd done something of that scale. But it's really stark when you look at the map here, that how quickly the first set of Lighthouse labs went from concept to operation and how much longer it took. And I have some empathy for why colleagues in the Cabinet Office felt that they needed to scrutinise, for fear of sitting in an inquiry such as this and explaining why they'd approved things out of process. But that's why through August we discussed with the Secretary of State and with the Chancellor and the Prime Minister how we changed the way procurement worked, because otherwise we were cutting off our nose to spite our face. We were slowing down when it was clear the country needed that testing and tracing capacity for the autumn, and every day really mattered.
Thank you. And then to inform the every day really mattered, did the data and information that you're receiving from the JBC further support that every day mattered to get greater laboratory facilities for tests?
Absolutely. And I think you can see in the emails, in the evidence, this is senior people sending emails at midnight saying, basically, I'm scared. I can't deliver what I know I need to because we're stuck in the bureaucracy and we need to find a different way of doing this. And so as you look forward, having crisis appropriate procurement processes. I'm not suggesting that scrutiny isn't appropriate, of course it is, but the risk of not building the labs was so much greater than the risk of spending 10% more on the procurement, and that wasn't being recognised in that summer.
And can I ask you then, because we know that until December of 2020, you had a reporting line to the Prime Minister, and so particularly with the frustrations you've expressed from the summer of 2020, would it be a fair assumption to say you would have been raising these frustrations in meetings that you were having with the Prime Minister?
Yes.
And what assistance did the Prime Minister give to you to essentially get a solution as quickly as possible?
Well, in the end, it was through the Prime Minister and colleagues such as Ollie Mann in the Cabinet Office that we negotiated a different process with the Treasury and with the Cabinet Office. But as I know in Module 2, my lady, you've been exploring, government decision-making is complex. And one of the things that you learn taking on the role that I did is that actually that politicians still need to find a point of consensus amongst their cabinet. And it took a while to get that consensus through the summer. And I do think that there were a lot of us as citizens who wanted to believe that it was all over and we didn't need to do it. And that was what was playing out amongst the politicians who needed to make these decisions.
Thank you. Now, Baroness Harding, last week we looked at some of Lord Valence's evening notes and caveating that they are not anything other than handwritten notes of an evening. But one of those entries was from the 6th of August 2020, which described people changing all the time, no one knows who actually is in charge of Lighthouse Labs. Can I ask, did the Lighthouse Laboratories suffer from a high turnover and unclear leadership in the summer of 2020?
I think everything is context dependent. So at that point, at the beginning of August, we must have been just at the point at which Chris Malloy, who I know has given evidence, was standing down as the head of the Lighthouse Laboratories, and Dame Anna Dominczek was taking over. So I can understand why Lord Valence would have been observing quite a cast of characters changing. It was also at the time where, if you think of the senior leaders that I'd brought in, had done their 3 months and we were changing. But I think it's a mischaracterisation to say that it was all unstable. It was a crisis situation where people were doing a tour of duty and then the next team was coming in. And, you know, Dame Anna had been leading the setup of the Glasgow Lighthouse Laboratory, so she wasn't new. She had been the dean of the Glasgow Medical School, is now the the chief scientist for Scotland for health matters. So Anna was deeply involved in the programme and was transitioning, I think, at that point. So I think, yes, in part, crises are chaotic and there were a lot of changing and moving parts, but I don't think it was more than you would expect given the rate of growth of the organisation.
Thank you. Can we then go back to paragraph 511, please? We've dealt with 5.10, which identified the ability from the 22nd of September to award contracts up to 150 million. But you then go on to say these challenges were further exacerbated by the inherently unpredictable nature of the pandemic. In December of 2020, NHS Test and Trace was encouraged to move towards a more business as usual environment and increase focus on value for money across the organisation, including in relation to procurement. Shortly afterwards, a new variant of the virus emerged, which led to the standing up of new use cases, such as the testing of hauliers at the border and of secondary school staff and pupils at very short notice, and the need for a third lockdown. This meant that simultaneously NHS Test and Trace was being challenged by the Prime Minister to scale faster and the Cabinet Office to slow down. And so it seems that is a tension throughout the year that you were the Chief Executive of NHS Test and Trace. Is that accurate?
I think the tensions were particularly evident at the point where very, very difficult political decisions needed to be taken. I don't think it's a coincidence that we're looking at this correspondence in December 2020 or that the previous point that we were talking about was August, September. In both cases, that was where, for a lot of us, we all wanted to believe that it was over, but actually the data and the disease had got a different plan, and the data was pointing to infections on the rise. So in December 2020, there were perfectly reasonable, very smart people wanting to believe that Christmas would be normal. But what the JBC was telling me and the Secretary of State for Health and the Prime Minister was that actually we urgently needed to scale, and there was a real risk of needing to have another lockdown. And my instructions were do everything you possibly can to mitigate the risk of that. And hence getting those very conflicting instructions. When there was a clear political path, so as we came out of the third lockdown, the path out of lockdown was very clearly documented with clear rules or guidelines for how government would make its decisions. Then government was completely aligned. Now, I'm not naive. I don't expect that in a crisis, government can be completely aligned and rely on a publicly published document. But in those particular points in 2020, NHS Test and Trace was being given directly contradictory instructions by different parts of the machinery of government. And I've no doubt in my mind that if there was a more structured process in place, it would still have led to changing instructions, but not entirely directly opposite ones at the same time, if there'd been closer. And I know that's more the subject of Module 2, my lady, so I'm sorry if I'm erring where I shouldn't.
Thank you. Can we then continue with questions on the Lighthouse Laboratories, please, and move to your paragraph 5.19, please, on page 24. Thank you. Now, you detail within paragraph 5.19 and 520 the expansion of the Lighthouse Laboratory network in the summer of 2020. Can I ask you, on the 23rd of July 2020, Vaughan Gethin announced a new Lighthouse Laboratory in Newport that we've looked together didn't come online until the October of 2020. The expectation had been that that laboratory would be up and running by August, but it didn't open until the 5th of October. Can you assist, please, Baroness Harding, as to how the location of the laboratories was identified and selected?
I'm sorry, I can't really give you an awful lot more detail on that. I'm sure that we can go back through the records and write to you if that would be helpful, but I wouldn't have been personally involved in the specific site selections. That would have been Chris and then Anna's team working through what they thought was the right sort of geographic location for the very complex end-to-end logistics, and to ensure wherever possible that all four nations were being appropriately supported.
Thank you. Can I ask you then, specifically with the Newport example, what was are you able to give the specifics as to why there was such serious delays in setting up the laboratory in Newport? Is it under the context of the discussion we've already had about the problems with getting the procurement for the continuation of the Lighthouse Laboratories?
I think all of these things are multifactorial, and it's tempting to make it one. I think that we've talked about procurement as being one. The sheer complexity of sourcing the equipment. Remember, there was a global race for all these PCR machines, recruiting the teams, making sure that the processes are clinically validated. This is a non-trivial exercise. I can't, I'm afraid, speak to the detail of exactly why that took what in COVID time feels like a very long time, but in normal time would still be probably about 10 times faster than you would ever sensibly set up a laboratory.
Thank you. Now, if we look at paragraph 5.21, you deal with the response of NHS Test and Trace to the demand for increased testing. And can I ask you in particular about paragraph B, which included procuring short-term PCR processing capacity from private surge providers. And can I ask you, therefore, are you able to assist us to was the reason and frequency for that linked to the fact that the Lighthouse Laboratories hadn't progressed as quickly as they could or should have done?
It was all forms of testing weren't proceeding as fast as we would want. So I think there are a number of exhibits attached to mine and to the UKHSA corporate statement that show you the complexity of going from 200,000 test capacity at the end of May to 500,000 test capacity at the end of October, and then 800,000 by Christmas. We were pushing every type of laboratory to expand as fast as they possibly could. So existing lighthouse labs, whether that was Milton Keynes or Randox or Alderley Park, pushing them to expand their capacity, that was about procuring more robotic automation. So automating more and more of the end-to-end factory, if you like. We were also pushing NHS labs across the country to expand theirs, less full automation there because they had less space, but they were still doing some of it, and then pushing for the new labs to get set up. And as it was approaching through September, that target of 500,000 tests by the end of October was looking at risk. So we were looking for any laboratories that were clinically valid to add into the network if we possibly could. So it was all of the above, my lady, not just one.
Thank you. Can I say, you identify in that paragraph, obviously, that using those short-term PCR capacity was more expensive,
Yes,
and difficult to oversee. And so was there actually value for money in going to this resource?
Making that value for money judgment, one of the things that the team were always doing was looking at the average cost per test and looking to drive that cost down as we got more and more scale. So as soon as you could, you would want to remove the most expensive tests on a cost per test basis, and also the ones that were hardest to manage and ensure quality and performance. So these were they were called surge labs for a reason. You didn't want to use them unless you absolutely had to. And so if we'd had more lighthouse capacity come on earlier, then logically you wouldn't have needed to use them as much, and logically you would have delivered more testing at a lower cost.
Thank you. Can I see then, you identified that you were essentially utilising every possible resource for sources of testing. The inquiry has heard some evidence in respect of, from Professor McNally, for example, about what could have been offered through the university network of their ability to scale up PCR testing, and with their connection to existing hospitals through the framework of medical schools, and also from the CRIC in respect of their facilities and their offer of testing. And so can you assist in terms of going to every available resource? Were you aware of the offers that have been made by a number of academic institutions and other research laboratories like the CRIC?
Yes, and I can completely understand why anyone who felt they could really wanted to contribute and help. I think that the laboratories in London were connected into the NHS Test and Trace Pillar 2 system in the autumn, sort of November, December time, doing sort of single-digit thousands tests per day. Now, I wasn't involved when the original decision was taken to set up the first sets of lighthouse laboratories. But I think, and I've thought about this quite a lot, having listened to a lot of the evidence in this module, I suspect that there was no other choice in March, April 2020 but to take those Thermo Fisher machines out of the universities in order to get them working 24 hours a day, 7 days a week. Not because the machines themselves couldn't work like that in the universities, but because the logistics that you needed to have them working 24 hours a day, 7 days a week, were of a scale that needed to be centralised. And I am obviously a retailer by background. I think of the laboratories as the warehouses. The piece that really needed to be local in testing was the testing sites, the shops. You needed to get the testing sites as close as possible to people who most needed testing. So actually, with the benefit of hindsight, I wouldn't change the decision on setting up the Lighthouse Labs, but I would change which are the testing sites that you open first, because the same scale national approach went into the testing sites. So I think the first testing site was in the car park of Boots head office in Nottingham, and the second was at Chessington World of Adventures. Both could only be accessed if you had a car. If you were doing this again, you'd set up your first set of testing sites in local community halls in Tower Hamlets, not in Chessington World of Adventures. So I think that it's a bit of a false dichotomy. I totally understand why the university leaders really wanted to help, and I think Lord Bethel said in a perfect world we would have been able to connect them faster, but you had to make choices, and you needed it sounds very mundane, but imagine 30,000 boxes. We all filled in and did tests and put them in the boxes and we sent them back. Imagine 30,000 boxes arriving in this room, my lady. They have to be unpacked safely because they might contain dangerous virus. They've all then got, all the waste from those boxes has got to be dealt with. All of the machinery, the robots need to be working 24 hours a day to work through what is a production line. And so to get to the scale that you needed in the summer of 2020, you needed that. Now, I do think, if I may, there is another way you could, looking forward, tackle this, which is why the Germany example is so important. If we had a slightly more regionally scaled pathology network in the UK along the lines that Lord Carter recommended in 2008. So you had high throughput pathology services for the regular diagnostic tests that we all receive from the NHS. In this modern world of data moving, that's perfectly doable because other countries do it. You would then have laboratories within our NHS ecosystem that would be more suited for scaling than the laboratories that we had in academia and the NHS in 2020.
Thank you. And can I just explore with you your paragraph 5.24, where essentially you deal with the analysis we've just looked at together around existing laboratory capacity. But if we go over the page, please, you essentially detail that it was not possible to scale at the speed required via existing NHS, PHE or university laboratories. A university or hospital laboratory that in peacetime may conduct a few hundred PCR tests a day did not have the space, systems or processes to conduct 30,000 tests per day within a couple of months. And this was the brief that was given to and urgently implemented by each Lighthouse laboratory. The evidence the inquiries heard is certainly Professor McNally thought that they could get to 3 to 4,000 tests a day. And obviously if you multiply that across the 40 universities that are linked to medical schools, there's that connectivity as well as other institutions, other universities that have the relevant PCR testing. And similarly, the CRIC, Sir Paul Nurse gave evidence that they, with support, believed he could scale to 10,000 tests a day, and obviously gave the example that you only needed then 10 places that could do that to get to the 100,000. And so can I ask you, in providing your statement and giving the answers you've just given, have you had the appropriate regard to what those that operated these laboratories believe was possible if they had been utilised rather than moving to the Lighthouse system?
I mean, I've thought about this quite a lot over the last couple of weeks, and I think that the thing to realise is the challenge of the exponential complexity of having multiple laboratories. So I've no doubt that Professor McNally and Sir Paul Nurse are right that they could have scaled themselves to a few thousand or 10,000, but we needed hundreds of thousands. And every time you add a new laboratory, keeping them working, all the machines, all the people working 24 hours a day, 7 days a week, requires you to balance the load of tests that are arriving to them. So you're creating an ever more complex system. And so what we had to do was make priority judgments. And the judgment was to prioritise the biggest laboratories first in order to scale quickly. Because, as I said, my lady, that doesn't affect your ability to deliver a localised service. And I do think when you look at the testing capacity for the UK compared to all other countries, there's only one country that had more testing capacity than we did by the end of 2020, and that was Denmark. Every other country, including Germany, was substantially less than we were. So it wasn't perfect. I'm sure that, again, with the benefit of hindsight, if you'd started all of this in January 2020, could you have got more of the university labs on stream a bit earlier? Maybe you could, but you needed to have those big scale factories. And because of the lack of machines, you had to take the machines we had in the UK, which wasn't a decision I took. It was a decision Sir Jeremy Farrar and Sir John Bell advised on before Test and Trace was started. But with the benefit of hindsight, I suspect that we'd all do the same thing again.
Thank you. Can I ask you, in terms of when we looked at the private surge providers, did the data issue not apply when you were using private surge providers about how you could get the results and data across, or was there a contingency for that?
I wasn't aware of any data issues while I was there, recognising obviously that after I left there were. But I think there is a sort of a higher level point to this, which the issues with the Immensa lab do show you, which is the added risk of having multiple small laboratories, that the quality assurance becomes exponentially more complex. And this isn't a static world. So during the year I was running Test and Trace, we learnt about the different genomic variations of COVID. We started implementing a genomic assay in the laboratories to be able to identify faster than full genomic screening whether or not you had new variants. That had to be, those new processes had to be rolled out to every single laboratory. So the complexity of doing that and the risk of making mistakes grows exponentially. And so I think you do have to be mindful of that when you're scaling, that you want to have fewer of these high quality, high risk environments if you possibly can.
Thank you. Now, can I ask you about the Rosalind Franklin laboratory that we've already seen came online in June of 2021, so a month after you had ceased as in the role, is that correct?
Yes, it was running pilot testing just while I was leaving.
But can I ask you, just broadly speaking, in respect of that Lighthouse Laboratory, which I think was the only one owned and operated by NHS Test and Trace itself, we know that I think by 2023 it was fully decommissioned. Professor McNally, for example, has described the Rosalind Franklin testing laboratory as an example of an investment waste. And that the Leamington Spa Lab never really made a significant contribution to the UK testing capacity or infrastructure. Can I ask, do you have any views as to that particular laboratory?
Yes, so the Rosalind Franklin Laboratory was very much the brainchild of Dame Anna Dominczak. We were all mindful of how much public money was being spent on this programme and how important it was to have an eye to the future and leaving a positive legacy. And Dame Anna's vision was to create a reconfigurable, high-throughput diagnostic laboratory that then could be used for public health screening going forward. At the same time, that her vision included the high-throughput nature of the Rosalind Franklin Laboratory. It used a particular form of PCR testing called ePCR that came from the agricultural sector, actually from testing of seeds, that was very, very large scale and would have enabled the cost per test to be substantially lower than the original Lighthouse laboratories. So I can understand why Professor McNally might not have seen the strategy because it wasn't available publicly, but the strategy that we were working to was, as the Rosalind Franklin Laboratory was being commissioned, if you remember at that stage the vaccine programme was rolling out, but we didn't know how much testing capacity would be needed for 2021 and 2022. And the vision was that you would close down the higher cost Lighthouse laboratories and use the Rosalind Franklin ePCR factory flows to deliver large-scale, lower-cost per test PCR testing through the rest of the pandemic. I can't speak directly for the decision-making that happened after that, but I do think it is a real shame that Anna's vision for a public health legacy of high-throughput testing that could be part of this government's vision for more focus on public health, proactive screening, it could have played a role, and that was very much what was envisaged at the time that I was there.
Baroness Harding, you expressed that as a real shame, bearing in mind the costs of the establishment of the Rosalind Franklin Laboratory. Would you agree that it's something far more than a real shame that essentially that whole laboratory has been completely dismantled and no longer exists?
I think the biggest shame is not taking seriously the importance of public health. That actually we, and I I believe Lord Bethell said this as well. One of the most important learnings for me working on this is that prevention is so much better than cure, and yet we spend so much more money, so much more willingly on the cure. And so I do think it's a great shame. And maybe it was an idea ahead of its time, but that vision that high throughput diagnostic capability coupled with a highly local, targeted public health system that really looks after the people who most would benefit from that support ought to be one of the legacies from COVID.
And very, very briefly on costs before we break for 15 minutes. Can we please just have displayed I&Q 528313? You've already referenced, I think, correspondence that passed between you and Lord Agnew. This is obviously the letter he sent on the 10th of December, covering a number of matters. If we could just move to page 2. We can see in particular he was questioning the long-term strategy for testing, and under the value for money raised the query in particular around the costings of consultants at £3 million per day. Can I ask, given the persisting problems with staffing, resourcing and equipment, what your view is on consultancy costs of £3 million per day, and whether that did in fact reflect value for money?
So I think you've also got in evidence Lord Bethell's response to Lord Agnew's.
Sorry, Mr. Hancock's. We do.
Yeah.
Yes, from the January, I think. That
yes,
came. Yes, we do.
And set this all out. So you ask a much bigger question, which is about value for money, and I think to answer a question on value for money, you have to first step back and say, what are you trying to achieve? So the brief that I was given, that the Prime Minister and the Chancellor gave me, was to build a testing and tracing service that would reduce the risks of much more painful lockdowns and other non-pharmaceutical interventions. And so you judge the effectiveness and the value for money of the spend on whether or not Test and Trace succeeded in reducing infection rates, reducing hospitalisation, reducing the amount of time that, as a country, we needed to spend in lockdown. There are a number of independent assessments of that. It's quite a complex thing to determine. So it's not an easy question to ask, is it value for money or not? But the evidence that I've seen, whether it is the RUM and the Kana models that were commissioned by UKHSA, or the Ernst & Young Oxford work that looked at the cost per test and concluded that the cost per test was value for money in terms of QALYs, so quality adjusted life years, which is the way that in healthcare we assess the cost of pharmaceutical interventions. Both RUM and Kana models concluded that the Test and Trace programme meant that we spent less time in lockdown. And that was worth considerably more than £3 million per day. But as I say, it is a complex judgment on whether or not and I appreciate when you look at this looks like an enormous amount of money, because it was an enormous amount of money. But as we went through earlier, the reason you had to use consultants was because we'd exhausted the pool of military and civil servants who could be deployed, and the team were working, as this letter was written, flat out to recruit civil servants, while at the same time the disease had a different plan for us, had mutated, and we were about to be asked to scale up even further. So, which meant actually that consulting costs had to go up again because we needed more people to make sure that lateral flow tests were delivered to secondary schools for testing in the first week of January.
Thank you. My lady, is that a convenient moment?
Certainly, I shall return at 25 to. I hope you're warned that we take breaks, but I promise you we shall finish you before we break for lunch.
Thank you.
25 to. Scott Wright.
Thank you, my lady. Baroness Harding, in the remaining 20 minutes that we have together, I want to deal with, please, just to identify, hopefully briefly Operation Moonshot, then contact tracing, a little more around support for isolation, and then finally issues that link to recommendations. So I set that out, bear in mind we've got those topics to cover. But I think Operation Moonshot we can cover fairly briefly, because you detail in your witness statement, obviously, the announcement by the Prime Minister in September of 2020 that he had the plan for a whole population testing. And you therefore detail at your paragraph 5.15 that you were among those who expressed concerns about adopting a whole population testing model. And then you go on at paragraph 517 to then say you were relieved that a more targeted testing proposal was then adopted. But can I ask you, when you had the responsibility for test and trace, and then the Prime Minister had his own pilot or plan for this mass testing, to what extent did that add to your burden or detract resources? I know ultimately those lateral flows were used as part of the full community testing programme, but can you help us to whether that was an added complexity on the timeline we've looked at from the September time to essentially those tests falling part of the community testing programme?
So, obviously my role was to try and build and deliver whatever it was that our political leaders wanted the service to do. But there's no doubt that pushing to try and test the whole population twice in a 2-week period was, I think, in my view, a bit of a distraction. There is a counter to that, which is it drove tremendous innovation in the team scouring the world for tests that were cheap enough, fast enough, easy enough to deploy. In August 2020, no one knew that it would be possible for lateral flow devices to work so effectively. And so you could make an argument that without the Prime Minister's desire to do Moonshot, that might not have happened so quickly. And certainly one of the things I'm proud of is that the team found tests that worked, developed a means of validating them, procured them, scaled them far faster than many other countries in the world. And it's not absolutely certain that you'd have had that without the Prime Minister's push for Moonshot. That said, I was deeply sceptical that it was practically possible to test everyone within a 2-week period. It would have involved having roughly 10,000 testing sites, and we'd been going absolutely flat out to get 1,000 testing sites. And what I learned from the public health experts was that you could test 99% of the population, but if only 1% of the population had the disease, you could actually fail to test anybody positively, especially if you were running a sort of command and control operation that scared away the very people most likely to have the disease. So I was sceptical about it. I do think it was a distraction, but it wasn't all bad.
Thank you. And you detail in this run of paragraphs essentially that it was not just you, but the Chief Medical Officer also had their concerns. You say it was not all bad, but would you agree that the Operation Moonshot was an example of poor decision-making by the government set in the wider context of what you were doing on NHS Test and Trace?
Well, I was trying to steer all the way through that autumn towards multiple use cases to reach the people most likely to have the disease. I think that looking forward, my lady, one of the principles for building a future mass testing and tracing service is that you should design for the disadvantaged. That you should, in every element, we've proven that you can have scale testing and tracing, and Moonshot actually led to a very wide range of different use cases, testing in schools, testing in all vulnerable communities. It made a huge difference. But if you designed with the principle of designing for the most disadvantaged first, you wouldn't have Moonshot, you would have had community testing first. And I tried through that autumn to keep presenting all the different options that weren't just testing the whole population twice in a fortnight.
Thank you. And so in giving that answer, so would it be fair to say that you were equally then pushing, having identified the issue for community testing of those most vulnerable?
Yes, I absolutely was. And we learnt a huge amount in Leicester in the summer of 2020, working really closely with the Director of Public Health in Leicester and the regional public health teams with PHE about how important it was to design differently for the most vulnerable. So testing sites populated by, brilliant though they are, the military and military fatigue scare people away. Testing sites with your local pharmacist and a friendly translator at the front of the queue welcome people in. Testing sites on the right side of the road for each respective community in their community centre. All of that makes a huge difference. And unless you design in that way, actually the risk is you conduct lots and lots of tests, but you don't have the impact of a test, trace and isolate system that actually addresses the disease and supports the most vulnerable.
Thank you. Can I ask you, you've just identified a number of further examples of learning that you identified in your year in office. Was there a handover of all these key pointers that you sort of committed to writing or passed on before you left as to what you identify as the most important thing for a future test, trace and isolate system?
Yes. All of us who worked on the programme knew that we were coming for a period of time and leaving, and worked very hard at doing lessons learned exercises all the way through. So, there are very detailed lessons learned exercises on each element of the Test and Trace programme, and I'm sure that continued after I left.
Thank you. Can I ask you briefly, as we move to contact tracing, one of the novel things that you identify in the statement was that all communications relating to NHS Test and Trace had to be approved by a number 10 communications team. Briefly, was that a problem, that essentially it all had to be approved through number 10?
Yes. It meant that particularly at times where it was very tempting for the performance of NHS Test and Trace to be the subject of debate rather than whether or not we go into lockdown, we in NHS Test and Trace weren't allowed to communicate publicly. There was a slight quirk to the system, which the number 10 comms team didn't block communication on regional and local channels. So we did a lot of, which actually is a very effective way of reaching vulnerable communities using community radio. So we tried to do a lot of communication with regional radio because that was a way out of the system. But I felt quite strongly that going forward, there will be a need for a mass testing and tracing service in a future pandemic. And whoever is leading that at that time, I think, my lady, you should think more like, for example, the National Cyber Security Centre, who have deep expertise but also permission to speak. And I think it's quite important that a future health protection agency is able to do that, because trust in a system like this is its most important quality. And I would be first to say that we could have done better at building society's trust in this system.
And I think you make that point. We don't need to display it, but on the basis that trust was so important, I think you detailed that request for you to essentially directly communicate on those issues was refused, and essentially you ended up feeling like NHS Test and Trace became the whipping boy.
Yes.
Can we then move, please, to contact tracing, please? It's dealt with in your witness statement, so I'll just be picking out particular paragraphs. But could we display, please, paragraph 6.7 at page 34? And I think this is an issue of preparedness that perhaps created the scale of the problem for you that you've identified. You say, prior to the COVID-19 pandemic, the United Kingdom did not have a scalable contact tracing contingency plan. However, the balance between data privacy and public health for the purposes of contact tracing had been extensively debated upon in many Asian countries post-SARS and MERS, with plans and legislation subsequently put in place. For example, public health authorities in South Korea were able to access individual credit card data to track potential contacts. On the other hand, the UK had not conceived the need for a national-scale contact tracing service, and therefore all discussions about the use of personal data in contact tracing started from scratch during the pandemic. Can I ask you, do you agree that this was a major problem with substantial adverse impacts, and one which could not be fully rectified during the pandemic, of really failing to not establish the necessary systems informed by SARS and MERS?
Yes, I do.
And then can I ask you, because obviously one of the reflections you have is around future systems and particularly data. And one of the complexities, I think, of data that we've encountered in this inquiry is blockages set on the basis of the complexities that go with health data. Do you have any reflections informed by your time about how that problem or issue can be engaged with to ensure that those don't become problems in future pandemics?
Yes, I think you have to think about three different things. You need to think about the data architecture, you need to think about the data policies, and you also need to think about the culture around data, all of which you can do the pre-work before a pandemic rather than after. So the data architecture, you need a local to national architecture for contact tracing. Countries that relied solely on local contact tracing had to suspend contact tracing in waves 2 and 3 because they couldn't surge capacity around the geography. So you need a national system, a data architecture. There's no reason why you can't have that in place and know how to scale it. You need to have a debate, a national debate about the data policies. So you couldn't, in the height of the pandemic, start a debate about how do we as citizens feel about the state having access to our credit card statements. But you could have that debate in preparation as other countries. And, you know, I'm not prejudging the answer, but it's really important that as a country we have that debate for our culture. Which takes me to the third point, which is culture. Health data is the data that we all hold most dear to ourselves, that we are most concerned about. And that makes the incentives for sharing data really hard to navigate because there are lots of negative incentives not to share, personally as individuals, but also within the health and care ecosystem. Academic research is founded on your data. There's lots of incentives not to share data with other bodies. And so I think there's a real, and we see this for 20 odd years in our National Health Service, we've encouraged different hospital trusts to compete with each other rather than collaborate and share data. So you've got to address not just the architecture, but also the culture of this being a national asset. And with that, bringing with you the trust of individuals, but also recognising that you can't be selfish about this, that we all are, we're only as safe as the most vulnerable person in a pandemic. And so you have to find a way of enabling that data sharing. I do think there's hope, because we need to digitise our health and care system anyway. Last week the government announced what in other sectors would be completely normal, the ability to track your prescription through the system, through to a pharmacy. If you go into a future pandemic with a properly digitally enabled health system, actually this becomes substantially easier, which is why, my lady, I think you have to think about leveraging the 150 billion spent on the NHS and social care, not just the money spent on the UK Health Security Agency, in order to drive change.
Thank you. Can I then briefly ask you, paragraph 6.5, you deal with the SAGE advice around, for it to be effective, needing the 80% figure. But we know that SAGE also advised on the need for there to be backward contact tracing. Can you assist as to why that wasn't incorporated, namely backward contact tracing, sort of across the board as part of the tracing system implemented, please?
I think you had evidence, I think it was from Ben Dyson, saying that we did integrate backward contact tracing into the system as fast as we possibly could. By the time I arrived, it was already acknowledged that it needed to be, but you had to build the system step by step. So step one was asking people to give contact details of people they'd been in close contact with for the previous 2 days. In order to backward contact trace, you have to go back much further. So that's a whole tranche more data. So we did build it. It was undoubtedly too slow. And again, if you were doing that from scratch, again, you would have that system all set up and ready to go.
Thank you. Would you agree that the contact tracing system rolled out in May of 2020 did not reflect the diversity and needs of the United Kingdom's communities, including the diverse language needs and barriers to equality?
I think that as we built the system, we looked and worked really hard to try and make the very best accommodations possible for all diverse communities. But as I've said earlier, my lady, I think that the principle upon which we were instructed to build the system was one of scale, and looking forward, I would start with a slightly different principle, which is start by designing for the most disadvantaged. And there's no doubt that that wasn't the principle that we were given. We were given design for scale. And I think you need to reverse those two round. And then the things that were done in terms of multiple language provision, ease of access for partially sighted or blind or deaf, all of those things would have been the first things you did rather than things we did through June, July, August, September and onwards.
Thank you. Can we then move, please, to support to those self-isolating? Paragraph 7.3, please. And I think with what you said at the outset, you've already made your views fairly clear about the importance and necessity of funding to assist those of the most vulnerable to self-isolate. But can I ask you briefly, at paragraph 7.3, you specifically identify that you were championing for an equivalent process to that provided that those who do jury service, namely a £64.95 per day type rate, to be an appropriate way of looking at how you support to isolate. Is that correct?
Yes, that was, yes.
Thank you. And I think it's right if we perhaps move forward, please, to your paragraph 7.8, please. And obviously the detail of the exchanges, but also the underpinning material that we have. You say this at paragraph 7.8. The UK spent proportionally much less than other developed countries enabling disadvantaged people to self-isolate. If we had allocated more of the NHS test and trace budget to isolation support, I strongly suspect that fewer would have died and infection rates would have been lower with all the benefits that would have been brought. Do you stand by that statement?
I do.
And can I ask, do you hold any responsibility here for the way the NHS test and tracing budgeting unfolded, particularly efforts to identify and get the isolation support in place?
Well, it's certainly the thing that I wish I had succeeded in persuading ministers to do. We had the money in the budget. No, we didn't spend all of our budget. And I also think that spending more on self-isolation would have reduced the need for testing. But I wasn't the decision maker. The decision maker in this was the Chancellor. And at every opportunity from June onwards, the Chancellor rejected the proposals. And in the end, that was not in my control.
Now, again, my summary of a lot of material and documentation, I think even when the support system came into place at the end of September, it was clear that there was identified low take-up, and I think you continue to champion for more to be done. And we can see on occasions describing it like banging your head against a brick wall. Would that be the best way to summarise the whole process and efforts that you made to seek to get appropriate financial support for those to isolate?
I think the more I learnt from the data, as I said earlier, the modelling showed that the best way to get an operationally effective test and trace system that would reduce the rate of infection and enable us to get back to a more normal life was to encourage more people to come forward for testing, and that the data told us that people weren't coming forward for testing because they were scared of the consequences of isolation. The more I spent time with people from disadvantaged groups, I had the qualitative evidence. They would tell me that personally as well. And yes, to be honest, it was intensely frustrating. And what you see through the paper trail, I found it quite distressing reading it, to be honest, because we did try really hard to persuade ministers that this would be a good thing, not just for the individual well-being of those disadvantaged people, but also economically. This was one of the ways you could have had less economic harm for the country as a whole. And I think that the Chancellor particularly, this was a point of principle for him. It wasn't I don't think there was any amount of data and analysis that I could have put that would have changed his mind. It was a point of principle that he didn't want to create an additional welfare benefit. Now, I do appreciate that this is a complex thing. And, before we had certainty that you could ask contacts to test themselves every day, it would have been possible, if I tested positive, for me to say to the contact tracing system, my 500 mates were all in the room with me yesterday, and they could all get their non-means tested isolation payment. So there is a policy conundrum there. But what I was unable to achieve was any substantive engagement in how to mitigate that policy problem, and to recognise that actually the policy problem of not supporting the vulnerable to isolate was a much bigger one. And that was, you can hear my frustration as I say it now. There was an intransigence to that I think was very sad.
Thank you. Finally, Baroness Harding, you have already spoken throughout your evidence about key reflections, learnings, and you detail within your witness statement from pages 44 to 48 other reflections. And I hope between us we've identified the key learnings that you wish Her Ladyship had to regard to. But I know finally, before concluding my evidence, you wanted to publicly acknowledge and thank those from your team at NHS Test and Trace, and I don't want to take away what you want to say, Baroness Harding.
Thank you. I did, if my lady will forgive me, that there were in total, at its peak, over 55,000 people who worked on this programme. And I'm not for a moment suggesting that we got everything right. There is so much to learn from this. But they were all people, whether they were manning testing sites in the snow, in the rain, in the winter, or sitting at home making those contact tracing calls, which are not easy calls to make to tell someone they've got to isolate, or whether they were civil servants or soldiers or commercial leaders. They all stepped up to serve, and I think we should all thank them.
My lady, there are core participants' questions. Thank you, Baroness Harding.
There are. Miss Parsons. Miss Parsons, if you look that way, you'll see at the back.
Thank you, my lady. Good afternoon, Baroness Harding. I ask questions on behalf of the COVID-19 Bereaved Families for Justice Cymru. I want to ask you about collaboration with devolved administrations, in particular the Welsh Government. This is addressed from paragraph 4.12 of your witness statement. We don't need to go to it, in fact. In short, I think you say that collaboration with the devolved administrations was crucial to the effectiveness of test and trace. And you give the example of the UK Government and devolved administrations board being set up to ensure collaboration and shared learning. Some in the Welsh Government have been critical of levels of collaboration. I'll take you to a quote from Mr. Gething, the Health Minister up until May 2021. He said this, it was in a statement prepared for this module: "There was more than one occasion where the UK Government made choices without consulting us or taking into account how Lighthouse laboratories would need to be integrated into the NHS in Wales, test, trace and protect, or a wider infrastructure." And then this: "The lack of consistency and quality of engagement by the UK Government meant that time, resources and energy were wasted, which could have been directed meaningfully toward a four nations fully integrated testing and contract testing system." Were you aware of problems or perceived problems with the engagement of the devolved administrations, in particular the Welsh Government? And if so, what were those problems from your perspective?
So clearly it was a very complex set of relationships at multiple levels. So, I can only really speak to the operational side of test and trace as opposed to some of the political engagement. So at an operational level, for both the National Testing Programme, for testing and for the JBC, we had members of staff from the devolved administrations embedded in the teams in test and trace. And generally, I think that operational embedding worked very well. Now, it doesn't surprise me at all that Mr. Gethin felt that there were occasions when that wasn't perfect. There were so many moving parts and so much change happening as the testing service doubled in size every 1 to 2 months. I'm sure there were moments when that operational communication wasn't as smooth as it could have been, but the embedding of representatives from each of the devolved administrations into the core team, I think, worked. At the clinical level, the 4 CMOs worked very collaboratively as far as I could see. They were providing us with very clear direction as a united team of CMOs. And I also observed, because I attended it several times, the 4 health ministers working very collaboratively. I think where things got difficult is well beyond my pay grade in the sort of big political discussions and decisions where it was beyond COVID, where certainly I experienced COBRA meetings where the policy that was being debated had been announced by one or other First Minister or Prime Minister before the meeting itself. And that was so beyond the operational sort of integration and communication that I was involved in. But I imagine, and I'm only imagining for Mr. Gethin, those are all intertwined.
Thank you. Then taking into account what you say about being involved only on the operation side of things, how, if at all, would you ensure better engagement with the Welsh Government next time round?
I think step one, don't break what isn't broken. So embed representatives from each of the devolved teams in any national service. I think the thing we didn't do that you might want to consider in the future is doing the reverse as well. So having national representatives in the devolved teams. So actually the data flow wasn't as good as it probably should have been from devolved activities back. So I give an example would be the Merthyr Tydfil mass testing trial. Actually, I was quite blind to some of that because rightly the Welsh Government were leading on it. But so I think we could have improved the operational integration still further by having sort of mirrored embedding in both sides.
Thank you, Baroness Harding. Thank you, my lady.
Thank you, Ms Parsons. Mr Thomas, who's that way?
Good afternoon, Baroness Harding. My name's Leslie Thomas and I'm representing FEMHO, that's the Federation of Ethnic Minority Healthcare Workers. Baroness Harding, you say the following at paragraph 5.29 of your statement, quote, if the national testing programme had been started in January 2020, when the NHS began planning to expand critical care capacity and ventilator beds, the government might not have had to ration access to testing as long as was necessary due to during the summer of 2020. Question, can you say what impact on setting up the national testing programme in January 2020 would have had to protect ethnic minorities and other marginalised communities early on?
I mean, it's hard to give you a quantitative answer to that question, but qualitatively it would have had to have meant that those communities would have seen lower infection rates, fewer hospitalisations and fewer deaths.
Yeah.
So I think, looking forward, it's really important that we recognise that you need to stand up a scale mass testing and tracing service immediately upon declaring that you're in a pandemic situation and not waiting 6 months.
Thank you. Do you consider it was a failing by government to have more attention on testing capacities than catering to vulnerable groups who needed more support to self-isolate?
I think I've already said yes to that in many ways. I think that it's not that scale doesn't matter. You've definitely got to build very quickly in a future pandemic a large-scale testing and tracing service. But if you start by designing for the disadvantaged, you will, as I said earlier, you'll have testing sites in the places that are most needed at the beginning rather than a few months later. You'll have the services easily accessible for the communities that are most likely to be the ones that will be ravaged by the disease. So I do think it requires a different mindset to building a scale system than the one that was had in 2020.
Thank you. In an email to Shona Dunn, dated the 2nd of December 2020, you said, quote, "The biggest concern is the very low-paid workers not being willing to come forward for testing because of the fear of the cost of self-isolation." And Helen Waitley, whose constituency is in Kent, raised it and asked you if you and I could support these two areas, that was Medway and North Kent and Boston Links, to work up what might make a meaningful difference, both financial and non-financial, in terms of support. Both communities have large migrant workforces living in dense housing, where I doubt our positive incentives will make a difference, but support for isolation just might. Question: seeing as you clearly understood the concerns being raised amongst these ethnic minority communities, did you ever communicate these views to Cabinet?
Oh, yes, many times. And I wasn't alone. I don't want to give the impression that this was just me. This was very much, as I think Ben Dyson said yesterday, a considered view of all of us working on test and trace and of ministers in the Department of Health and Social Care, not that I should speak for them. And I, as I said earlier, I feel like I'm still campaigning on this topic.
Can I move on to another topic, which is public communications? The evidence has shown that some communities, particularly ethnic minorities, experience barriers to trust due to a lack of cultural competence in public health communications. You seem to agree with this sentiment in your statement. So the question is, I suppose, from your perspective, how can we ensure more effective public health messaging around testing, tracing and isolating for a future pandemic, especially for communities with historically low trust in government and state-run services?
I think that's such an important question. And I know that Dame Jenny Harries cares deeply about this topic as well. If I may, I can tell you what I learnt in Leicester is that there is no substitute for talking directly to those communities themselves. There's a danger that you have an argument about is it national government or local government who should lead on this. And the reality that I discovered is that most of these communities don't trust any government. It's their own local community leaders that they will trust. And so building in listening, access to those community leaders, you can only do it locally on the ground. But just because you're on the ground doesn't mean that you will necessarily hear them. So you have to create a culture where local community leaders feel there are safe spaces for them to speak up. And that's a problem for society in the round, not just for pandemic response.
Well, that leads me on to my next question, which I suppose is tied into it a bit. To what extent do you believe that institutional bias or a lack of consideration for ethnic and socioeconomic disparities influence who was able to access testing early on?
I think that this is something that is much broader than testing and tracing, and you could ask that question of any public service. I think that one of the examples that really struck me was in the early days, we opened a testing site, I think it was in Birmingham, and it was right opposite a taxi rank. And no one initially could understand why the testing site wasn't busy. And it wasn't busy because the predominantly ethnic minority taxi drivers didn't want to get tested because they couldn't access benefits because they were making good money as taxi drivers, but they had to be able to pay the rental on their cars. And so they just couldn't risk getting tested. So even though the testing site was right next door, they didn't use it. And so I think the premise of your question is correct, that for no sort of conscious fault, the system didn't work because we didn't have the isolation support in place, because we hadn't really heard how challenging it was for particular communities, professions, roles to comply with what was a very, very difficult system called isolating for 2 weeks.
Finally, do you think there was adequate consultation with community-based health organisations, particularly those serving minority communities, in the development and deployment of communication strategies regarding testing and contact tracing?
There's probably never adequate. You could always do more in this space. We worked really hard from the very beginning when this NHS Test and Trace launched at the end of May to engage and listen and learn. We had a series of sprints into different groups that's detailed in the UXA corporate statement, and we kept learning. But I think that, as I said, so probably repeating myself, this is something that you can't do too much of. And with the absence of preparation, everyone was starting where you wouldn't want to be. So this is something that you should be building into your pandemic preparedness, so that it's not something people have to think about on day 2. It's something that's been thought of on day minus 1,000.
Thank you, Baroness.
Thank you, Mr. Thomas. Mr. Weatherby, who's just there.
Baroness Harding, I ask just a few questions on behalf of the COVID Bereaved Families for Justice UK group. You've identified recruitment as one of the key challenges faced in the scaling of NHS Test and Trace. And that persisted, didn't it? And for example, you discussed in an email exchange with Gareth Williams from the DHSC on the 20th of August, the problem of a large recruitment gap of thousands of vacancies. I won't take you to that, but just for the record, I'll give the reference, which is INQ 000592556. But it's right, isn't it, that at the time you were appointed, there was no emergency plan to create a national test and trace, isolate and support system. And in turn, that meant that not only was there not a structure for that, but there was no recruitment infrastructure. And that would include recruiters, relevant IT, human resources, and perhaps crucially, a cadre of key workers to be seconded. And that was the underlying problem of the recruitment issue, wasn't it?
Yes, and I think it's actually broader than that, in that I don't think in any of our civil contingency planning, in any of the potential risks on the National Risk Register, had anyone thought that you might need to build a national citizen service that would need to employ tens of thousands of people within the course of 6 months. So there wasn't any plan to pull off the shelf to say this is how you do it.
As a follow-up to, in your recommendations, you've referred, and this morning you referred to a public health reserve resource. Would you add to that a resource for recruitment?
Yes, I would.
Yes,
I would, and some of the other corporate services.
Yes.
Sorry to use very corporate speak. The human resources, the project management, the IT development, that regardless of the nature of the emergency, if you need to scale a service up of this sort of scale, how do you do it?
You need I think infrastructure.
We should have that plan as a country.
Okay. I'm going to move on quickly because I've got very limited time.
Sorry.
But next topic, different topic, specific topic about the accuracy of testing. On the 29th of September of 2020, you reported to the COVID-O committee chaired by Mr. Gove, now Lord Gove, and I'll just give the reference again for the record, INQ 40090086. And you reported to that meeting that between 2 and 2.5% of all tests were being voided each day, and that was mainly due to the leakage of the equipment, the tubes in particular. Was that a persistent problem, given that here we're talking about September?
So I think that this was taken from the standard daily and weekly reporting that we shared on the performance of each of the Lighthouse laboratories and all of the testing channels and the different testing routes. So you would always have a percentage of voids, whether that was because test tubes had got broken in transit, whether or not they'd not been closed properly and sealed properly, whether or not there'd been an error in the processing in the laboratory. There was always, either human or robotic error. The percentage void rate was monitored extremely closely across every single lab and every single channel to try and identify potential issues.
Yeah. So, but would you agree that the 2 to 2.5% is a significant percentage? That would have impacted the efficacy of the system as a whole, but also confidence in the system.
Yeah, I'm afraid I can't remember what the range of voids were, and I'm sure if my lady needs to, we can dig that out. One of the concerns in the early days was that the home testing route would have a much higher void rate than the supervised testing route. It turned out actually we were very good at swabbing ourselves, and the home testing route was about the same. But I'm sorry, I just can't remember whether 2.5 was above normal or not. But it was never going to be zero.
It was significant enough for you to raise it a COVID zero, COVID-O.
I think, sorry, just to correct, I think that was more that one of the members of COVID-O was remarking on the number and asking me a question rather than my raising it directly.
Are you able to help us how this was addressed?
By continuous process improvement. Again, this sounds very small and detailed, but getting to a uniform size and shape of test tube made a very big difference to the performance of the end-to-end laboratory system. Changing and continually improving the instructions on the test kits to make it easier, improving the materials in the bags. This was the sort of industrial process re-engineering that the team was continually doing.
Yes, okay. Next topic. You've referred to the business approval for Lighthouse Labs issue that arose in July of 2020. So in an email exchange with Gareth Rhys-Williams between the 22nd and 27th of July, and again for the record only, INQ 000575993, relating to the business approval that you were seeking for extension of the Lighthouse Labs. He raised a number of questions around value for money, including whether taking a cost per test approach was appropriate, efficiency, and the requirement of improvement and turnaround times. So the question is this: given the persistent issues relating to staffing levels, leadership, potentially equipment in Lighthouse Labs, which impacted testing capacity into the autumn, should the contracting have been linked to efficiency and output as well as cost per test?
Well, cost per test and bringing cost per test down is an efficiency measure in some ways. And all of the questions in Gareth Rhys-Williams' email are completely legitimate questions.
Yes.
They were questions that his own team had been working through before. And so the reason I was challenging it was not that it was inappropriate to look at how do you drive efficiency. It was more that we risked failing to open up the testing capacity while we reopened the same debates that his own team had reviewed in the previous few days.
Yes. Now, you've been asked about Lord Agnew's letter of the 10th of December, which was about the long-term strategy for testing, and you've been asked about the particular reference to previous consultancy was costing £3 million per day, and the question, what trajectory do you anticipate and what governance exists around this deployment? And you referred to Lord Bethel's response of, I think, the 10th of January of 2021. We haven't got time to go specifically to that, but my lady has it. But my lady may come to the conclusion that on this particular point of value for money, that letter doesn't in fact say very much. Are you able to help us how value for money in this emergency context, the cost of the taxpayer, was assessed during the 6 months between May when you were appointed and December when Lord Agnew's letter was written?
Yeah, I tried to set that out earlier, but maybe if I can unpack it a bit more. So we commissioned a number of independent reviews to establish the efficacy of the testing and tracing service. So the RUM model, the Kana model, and then after I left, the UK HSA commissioned Ernst & Young and Oxford University. All of those were attempts to assess the value for money of the testing and tracing service. And as I said, I think one of the most important conclusions to draw in this module is that population scale testing and tracing can be value for money.
Yes.
It's very dangerous and very tempting to assume that scientific developments in the future will mean we don't have to have a system of this scale in the future. I think that would be a huge mistake.
Yes. Okay. Final point. You've been asked about Operation Moonshot. In your view, did the government support for Operation Moonshot take priority over financial support for those who were required to isolate?
Well, I think the facts sort of speak for themselves in that, yes.
Thank you very much. Thank you, my lady.
Thank you, Mr Westby. Mr Jacobs is right down the end by the clock.
Baroness Harding, just a couple of questions on behalf of the Trades Union Congress. You have given evidence about the principle and importance of financial support for self-isolation. I'm going to ask you about the mechanisms for delivering it effectively, okay? To be effective, presumably a scheme of support needs to be one that is accessible to those who need it. Did you have reflections on whether the scheme delivered as it was by local authorities with their own approaches and criteria was sufficiently accessible?
I think despite local authorities' brilliant best efforts, the evidence would suggest it wasn't, that it was too complex a means of delivering. And because it was different from other benefit systems, people didn't know it existed. The people who most would benefit from it found it hard to find.
Acknowledging, of course, the very important role of local authorities in test and trace response, would it be your view that the appropriate mechanism for financial support is one delivered centrally rather than locally?
I think you need to have a bit of both, but yes, I think fundamentally the debate we need to have in peacetime, if you will, is what that sort of isolation support payment should be. And I would suggest a national system delivered probably via a DWP is a better thing to do than creating something completely different.
In terms of eligibility for support, the Test and Trace Support Payment Scheme, in broad terms, operated along lines of eligibility for in-work benefits. Was that too narrow, in your view, in that it excluded people who would feel the disincentive to self-isolate, but were not eligible for any support under the scheme?
Yes.
In terms of the amount of payment, in England, £500, some variants elsewhere in Wales, for example. What were your reflections on that?
I mean, as you can see from my evidence, personally, right at the beginning, I thought that you should sort of take the benchmark of jury service, a different but similar example where we ask people to perform a public service. But I think that this is, as you look forward, exactly what the government should consult on and settle before you're in a pandemic, not during.
And if we look at the purpose of financial support, if the purpose is to remove the disincentive the financial disincentive to self-isolate, is the simple way forward, in your view, to have a scheme which provides sufficient funds to remove it entirely?
Yes, but it is, as I said earlier, also quite complex to make sure that you don't have sort of unintended second and third order consequences. So, you don't want to incentivise people to get the disease either. So it's important to get that balance right. And what I would say is that other countries
I think, got that balance right, both in Europe, in Australia and in Asia, in a way that we didn't.
And I know you give some examples in your statement. Thank you very much, Baroness Harding.
Thank you, Mr. Jacobs. That completes the questions that we have for you, Baroness Harding. You raised some really important issues. There are a number of themes that go on as I go through the inquiry in different modules. Planning, or lack of planning. Can't tell you how many times, well, you've probably gathered, I'll have heard that. The other is the number of unsung heroes and heroines of the pandemic, and you've mentioned many thousands more, and I totally agree with you that we owe them all a huge debt of gratitude. I mean, people were working till they were, as you say, absolutely exhausted, making themselves ill very often in the process. But I also think we owe you a great debt of gratitude. You didn't have to take on the huge task and put yourself in the firing line, and I know that you have put yourself in the firing line. So thank you for all the work that you did, all that you tried to do, and thank you for your very helpful contributions to the inquiry.
Thank you, my lady. That means a lot.
Thank you.
My lady, can I briefly just apologise to you and Baroness Harding? When I put the letter from Lord Agnew, I incorrectly said that the response letter had come from Mr Hancock in the January. In fact, as Mr Weatherby's just identified, it in fact was Lord Bethell in the statement of the 15th of January 2020. So I apologise to you and Baroness Harding by misleading you in that question. Thank you.
Thank you very much.
Remove all my stuff.
Sorry to keep you, Dame Jenny.
Thank you. Could I ask, please, for Professor Dame Jenny Harries to be sworn, please?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth and nothing but the truth.
Thank you. Could you please give your full name to the inquiry?
Jennifer Margaret Harries.
And can I check, I apologise to ensure that I get things correct. Do I refer to you as Dame Jenny or Professor Dame Jenny?
Any will do. I think it's been Professor Harries through most of it because that's for other people, so I'm happy with anything.
I'm grateful. Can we first of all please identify the witness statement? And in fact, on this occasion, Professor Harries, you provided a corporate witness statement on behalf of UKHSA. If we could please turn to page 114 within that witness statement, dated the 14th of April 2025. I can ask you to confirm, is this statement true to the best of your knowledge and belief?
Yes, it is.
Thank you. In identifying that you are here to speak to the corporate witness statement and appreciating also that you talk about legacy matters, there are a number of questions that I will be dealing with this afternoon where it goes back to earlier statements you provided in a personal capacity. So can I just make that clear at the outset? But can we then please identify together, in fact, you're speaking to, I think, what's the 13th corporate witness statement on behalf of UKHSA that's been provided across the modules. And I think you yourself have identified that you have given personal witness statements across modules 1, I think 2, 3 and 6.
Everything but 5, I think.
Yes, and so can we thank you once again, Professor Harries, for the care taken to provide this corporate witness statement on behalf of UKHSA. Can we then please just identify your relevant experience and expertise over the time period that we'll be looking at together today? I think you identify that during the relevant period we'll be looking at, you were the Deputy Chief Medical Officer from 15th of July 2019 to the 31st of March of 2021.
Yes.
Then you essentially took over from Baroness Harding. I think you tell us at your paragraph 1.6 that from the 1st of April 2021, you essentially became the Executive Chair of NHS Test and Trace, formally taking up the operational role from the 7th of May 2021, when Baroness Harding completed her 1 year of service.
Yes, so nominally from the 1st of April, following Baroness Harding on the 7th, and operationally fully then for UKHSA on the 1st of October.
Thank you. And I think We know that UKHSA as an organisation, I think, had been referenced in being from the April of 2021, but as you've just identified, did not become operational until October of 2021.
Yes.
And so are we right then for the period from the 7th of May of 2021 to essentially see you as performing the similar role as the Executive Chair of NHS Test and Trace?
Broadly, yes.
Thank you. Now, you plainly have detailed within your witness statement the extensive relevant experience you have. And so please excuse me by not going through all of that, but perhaps of significance to what we're going to deal with today. It's right, isn't it, that from April 2017 until July of 2019, you formally held the Strategic Incident Deputy Medical Director role at Public Health England.
Yes.
You also, alongside that, you were interim Deputy National Medical Director for PHE from 2016 to 2017, providing specific support for strategic incident response.
Yes.
And then even before then, you have relevant experience as the Director of Public Health. You tell us that you were Director of Public Health in Norfolk and Waveney, Swindon and Monmouthshire. And you were also a Chief Officer in Norfolk and Waveney and Swindon.
Yes.
And so you have relevant public health experience alongside all the other qualifications that you've detailed in the witness statement. Can I ask you specifically then, is there any other relevant experience that you wish to particularly draw to the fore by reference to what we'll be looking at together in Test, Trace and Isolate?
I don't think so. The point about having DPH experience both in Wales and in England, but also obviously I've worked in hospitals and in primary care as well. So it's a lens, I hope, that has looked through many of the different views that the inquiry will cover.
Thank you. And so then bringing things up to today's date, you are the Chief Executive of the UK Health Security Agency. And in fact, I think you've already formally announced your retirement. And so your position in this role is perhaps coming to end, is it soon?
I have slightly postponed it in order to be here, so I finish on Friday.
Well, thank you. Now, can we then just identify UKHSA again? Her Ladyship's heard quite some evidence about UKHSA, but let's identify it as an organisation. If we could display your paragraph 1.2. You confirmed that UKHSA is an executive agency of the Department for Health and Social Care and carries out certain statutory functions for the Secretary of State for Health and Social Care.
Yes.
It was fully operational from October of 2021. And UKHSA's role is to protect the public, not only from infectious disease, but also from external hazards such as chemical, radiological, nuclear and environmental threats, and brings together expertise from predecessor organisations, including Public Health England, NHS Test and Trace, the Joint Biosecurity Centre and the Vaccine Task Force.
Yes.
Thank you. Now, with the time we have together today, Professor Harries, I'm not going to be dealing with the whole chronology that you detail and set out in terms of the legacy organisations, then NHS Test and Trace and also UKHSA. But please be assured that this statement will be published. And so can we then perhaps start with the first topic, please, of preparedness, please? And if we could turn to your paragraph 3.31, please, at page 24. Thank you. Now, you detail within the witness statement that as of the 1st of March 2020, PHE was able to process up to 2,100 PCR tests per day, i.e. collected, delivered and processed by laboratories. PHE laboratory capacity had been required for the delivery of its public health specialist functions and to support the NHS. Therefore, the government strategy reflected the fact that PHE had never been resourced to undertake large-scale population testing or tracing, and the need to focus efforts on scaling capability and capacity rapidly. And so can I ask you in that context, had the risk of a pandemic requiring large-scale testing and tracing been assessed by PHE and or across the government?
So the role that Public Health England had and was specified in its remit was providing specialist public health laboratory services. And what that means is that clinical care, normal clinical testing of patients with infections would be part of the NHS responsibility. And the role that Public Health England did would be, if you like, for sort of rare diseases, so things like Ebola, things entering the country, but also it's had specialist labs looking at things like antimicrobial resistance or specialist reference laboratories for meningococcal disease or flu viruses.
Remember, we have a stenographer.
Sorry. And then also used its services for things like surveillance, so looking at tests for that. But routine testing and for large patient numbers would normally be part of the NHS's responsibility.
And can I ask you then, in terms of PHE's role, obviously this referenced PHE laboratory capacity. Do you know whether there have been any preparedness work, and particularly post MERS and SARS, that had looked at what else existed beyond the PHE laboratory, such as the virology network, and how that stood in 2020, please?
So I think this goes back to my first point, which is they would tend to be specialist public health laboratories. So as I know Her Ladyship has heard, the test, the assay, the diagnostic assay, was actually part of the work of that virology network. It was internationally linked in and was specialist work. So it was that sort of lab work, the initial phase of testing that would normally be the responsibility of Public Health England. It had never, been funded, and I don't think it had been assessed for whether it could roll out into a very large system. The role it took was to expand to its own labs, but it wasn't responsible at the time and was never funded to go beyond that level.
Thank you. Can I ask you then, with the current state of affairs as of 2025, does there now exist essentially a directory that identifies what laboratory capacity there is existing across virology, pathology, that actually identifies where the laboratories are with the specialism to scale up in a future pandemic?
That's quite a complex question, which I'll try to answer. So we have reviewed, and we have a programme of what we call agency surge capability and preparedness across UK Health Security Agency now, which includes our labs. In this case, the reference virology labs are mostly based at Colindale, and across some of our regional laboratories. The rest of the laboratories are either private sector or they are owned by the NHS. So I know where our capacity is, and I can talk later about how we're trying to work to increase our capacity and speed of surge. I do not have control over other parts of the laboratory systems.
I appreciate that, but in terms of an identification of where across public and private the laboratories sit, is there anyone that's collating that information? So there's an understanding of infrastructure, both publicly and privately owned.
We have quite a lot of good information, and we work very strongly, which we may come on to, with various elements of the private sector. But the overarching responsibility for pandemic preparedness sits with the Department of Health. And so what I try to do is, within our boundaries of finances, which we may come on to, is create our responsibility to that boundary and then seek out. And we are working with others, but I don't think we have mapped out precisely where those will be. We are exploring. We've done some market exploration ourselves to do that. I think what you're asking is, has somebody nationally done that?
Yes.
And I think that would normally sit with the Department of Health and also with the Office for Life Sciences, who deal with many of the those companies regularly.
Thank you. Well, perhaps we'll look at that when we look at recommendation, because I think you do give some understanding as to what UKHSA would have available by way of testing.
Yes.
And I think, is it somewhere in the order of 3,000 tests a day that would be essentially?
That would be the smallest amount, because that would depend on high containment level, which we've discussed. We could surge up to 12,000 if the containment level was lower, and we are actively working in that preparedness plan, hopefully with an update by September and within our means, to have under our direct control up to 25,000 tests within 6 weeks, because of the experience, I think, of the last pandemic, we feel that it's important that we can surge further than was available previously.
Thank you. Can we then please, I've already highlighted that I'm taking you back to your earlier statement. Can we please go to your fourth statement, which is INQ 273807. It's page 142, but it's your paragraph 10.5 and 10.6, please. So that's INQ 273807. Thank you. Thank you. You detail that testing and contact tracing does not, however, confer the same benefit for all diseases. In the context of seasonal influenza, the disease usually has a relatively short incubation period of 1 to 3 days. The consequence is that once exposed, people rapidly become symptomatic and infectious themselves. Contact tracing aimed at identifying these people and enabling their absence from societal interactions before they've had the opportunity to spread the disease is therefore more difficult. And then you go on further, as a disease transmitted predominantly by the respiratory route, influenza can be spread to large numbers of people who might then prove difficult to identify, and obviously you give the various examples of that. Accordingly, the opportunity to test an individual to identify them and to intervene before they have had the opportunity to spread the disease is correspondingly lower. The consequence is that testing and contact tracing are likely to be of less assistance in the control of the pandemic, with pathogen characteristics similar to seasonal influenza. Accordingly, widespread testing and contact tracing has not historically been employed successfully or recommended in the management of influenza pandemics. Can I ask you, did the failure to consider and or develop contingency plans for rapid scaling of testing and tracing prior to 2020 result from excessive focus on the risk of a pandemic influenza and lack of focus on the public health interventions which might be required to deal with a pandemic caused by a novel pathogen?
From my own perspective, I don't think it is the influenza that's the, the important point. I think, but I do think you have hit upon probably what for me is the biggest learning from this, not just for the UK, but for almost all Western countries, which is actually in nobody, I think, had really caught up with the 21st century. Nobody had really thought through, can we test at the scale that we now know that we can, following the work which NHS Test and Trace had done. And so, and probably in a resource-constrained environment as well. It's very unlikely any public health person would have thought that resource would come forward to do that sort of scale of testing. So I think there is a point which is both on moving into the 21st century and what was possible in the way of testing and digital infrastructure, but also considering asymptomatic transmission as well. And those two combined, if put at the front of this, so almost forget the pathogen, but put those two at the front, and then the scenarios of the art of the possible in pandemic preparedness changes considerably.
Thank you. And then can I ask you in particular, you'll know that a lot of the questions of a number of witnesses have related to asymptomatic transmission, and you seem to be saying that needs to be considered at the start of the process now as an assumption. Is that?
So asymptomatic transmission, and I think the inquiry has had evidence frequently, it is always considered, I think, by individuals who understand infectious diseases. The issue is the proportion of the cases which are asymptomatic is a really important one, because if it's 0.1%, you probably wouldn't set up a system designed around asymptomatic transmission. But the consideration of it in pandemic planning, or indeed in any infectious disease outbreak, is really important. And I think that is one of the big learnings from this pandemic. It is a general point which says each time we look at a potential pathogen, its characteristics and what it could do, we need to think, what would the differential response be if a large or a small portion of this proportion was asymptomatic transmission? And I mean, we are trying to do some of this work we may come on to in looking at priority pathogen families, setting that framework, looking at the testing that we can develop ahead of any potential outbreak or pandemic.
Thank you. Can I ask you, in terms of the approach that was adopted in the COVID-19, are you able to assist as to why the UK government did not follow the approach of South Asian countries in creating a rapidly scalable TTI infrastructure following the response of SARS and MERS, or even contingency TTI plans?
I think it goes back to the points which I've just said. In the environment, and it wasn't just the UK. I mean, I think it's very important. It was all systems, more or less, I think, outside Southeast Asia, where they had direct experience, so maybe that is significant. I don't think there was a belief, perhaps, that you can stop a pandemic or curtail it in such a way. You can see from the historic teaching almost for infectious disease management in large outbreaks like this is that you will change your definition of a case as the outbreak progresses. And that's exactly what happened through COVID. We changed, the first cases definitions. Excuse me. The first definitions were travellers coming back from Wuhan. Then it changed to people in a wider geography. Then it changed to those who needed, for whom you need tests for clinical care. And then when we had a wider system, it changed then to those, universal testing. I mean, that's probably all I can say at that point.
Okay, thank you. Can we then move, still in this witness statement, please, your fourth witness statement, to paragraph 5.21 on page 24, please. Now, you highlight in paragraph 5.21, I was aware from my previous roles, however, the excellent scientists and very committed teams within PHE who regularly provided internationally recognised health protection expertise, as well as direct contributions to local, national and international infectious disease control and scientific understanding. I was also aware of the resource constraints of that organisation. These included sustained reductions in funding over the life cycle of the organisation, with a 40% reduction in the overall PHE budget between 2013-14 and 2019-2020. And so are you able to offer any views as to whether resource constraints inhibited effective pandemic preparedness as far as test, trace, isolate infrastructure or planning was concerned?
So I can speak with some personal experience of this because at the time of much of this, I was the regional director for the South of England, for Public Health England, and even our frontline, what I would call routine health protection teams, which have been very active during COVID, were at a bare minimum when I left the organisation. I think it's had two impacts. Number one, there was no flexibility. It was continuing to do vast amounts of work, including international surveillance on what the budget of one medium-sized hospital. I mean, it's quite so an extensive emergency response system across the country for more than just infectious disease and international work. But I think also what's happened is, and I referenced it earlier, it probably resulted in a bit of a minimalist mindset in the sense that if every time the budget cycle came round, it was cut, the idea that you might start thinking through, I mean, this is my own reflection and not evidence, but it wasn't in the psyche to start thinking through if somebody injected £1 billion here, could we set up a new testing system for potential for a pandemic? Because it was effectively a breadline health protection public health service.
Thank you. And then can I ask then as to how things currently operate with UKHSA with a health protection service essentially? Is that appropriately funded now, so not operating on the breadline that you've just identified that PHE England was?
So I think I have shown the efficiency of myself and the management in the reduction of our budget. So I think I'm advised, have delivered the largest single downsize in the budget post-war from 15 billion to 3 billion in 1 year. And my overall budget now, there are slightly different figures I know have been presented because we have vaccines budgets running through the organisation, if you like. But we are back to effectively one medium-sized hospital for our systems, despite the fact we are now running a whole load we are a new organisation. We do genomics, we do data analysis, a whole load of new things. So it's difficult to say because I absolutely recognise the resource constraints of the current system, and that is important, and therefore I do my role and work within the budget. I do raise issues where I think that is difficult for health protection, and where they are important for the protection of the public. But nevertheless, the decision finally on the resource and the surge capability and expandability of the service relies on risk appetite and ministerial decisions, and quite rightly those are political decisions. The one thing I would say is I will fight very strongly to maintain baseline capabilities. So losing scientific skills in an area where you stand no chance of surging them again, or reducing to a certain level where they are not operable, is an area where I call a red line. And we are not there. We have a very good service in this country, and I'm very aware that actually some of our really important areas, things like our high containment labs, have been noted publicly to be under immediate consideration in the spending review. But we are in a very different place. I think the vision for the organisation when I came in is probably not achievable on the budget that we have at the moment.
Sorry, under immediate consideration for a decrease or an increase?
No, so there is a particular issue, and I say it here because it is in the public domain and has been the review for National Audit Office and the Public Accounts Committee for replacement of the countries, so which UKHSA oversees high containment laboratories. So these are the CL4 above CL3 pathogen level. So there has been a significant amount of urgent consideration. The runway into building these is actually about 15 years. And so there's been a delayed programme in the country that should be, I know, is under active consideration for the spending review this year.
Thank you.
Thank you. Can I pick up on the red lines and what is appropriate and necessary, just deal with at this stage? Obviously, the roles you've had at UKHSA have involved essentially the mothballing or dismantling of the UK Lighthouse laboratories. And perhaps the most significant example of that being the Rosalind Franklin Laboratory, NHS Test and Trace owned, that had a vision for a long-term role, we've heard, when created, that it would exist beyond a pandemic. Are you able to assist, or whether you're a party to, or any of the discussions around that decision to essentially dismantle the whole Lighthouse Laboratory network that had so much public funding invested into it, but specifically where Rosalind Franklin was wholly owned by NHS Test and Trace?
So actually important objective thing, the Rosalind Franklin Laboratory, it was actually leased, so we need to be quite careful about who owned it and whether it was sold or not. I think the key point you make is it has ceased to function, and I do have some insight into that. I mean, clearly all of these decisions are ministerial decisions. They're not ones that I make on my own, and each time a decision is made, it will be a balance between highlighting what I've been asked to do in the budgetary constraint, for example, and making sure ministers understand what the impact of that might be. I think for the two different areas, the Rosalind Franklin Laboratory was not... I didn't conceive the idea, I wasn't part of the original business case. And there is a reflection on that, which I think comes back to perhaps nearer the end about looking forward on making sure that where we are investing as a country, where government invests in different building structures and programmes, they are aligned, and there is a case for them to be running in peacetime. That was not the position with the Rosalind Franklin Laboratory. And in fact, my own organisation put in a very, very significant amount of work almost retrospectively to try and work with academia, with local universities, with the private sector, to see what could be made of it so that it could continue to run and then in the future turn back to being something that we might be able to use in the event of a pandemic. That was not possible. And I mean, I think the costs for maintaining these are quite staggering. I think if I remember correctly, and I might need to confirm after, it's about $500,000 a month for it not to be working, if you see what I mean, just sitting there. There are also, another key point, issues to do with maintaining staffing of these establishments as well, which was always a problem. So I think on the face of it, it looks like a huge loss. It actually, in fact, only, I think, at the peak delivered 125,000 tests a day of the 850,000. So I wouldn't personally necessarily say that was the crown jewel, if you like. I think we need to be really, really good, systematic over the long term at looking at what we're building and how we build into it the functionality to turn it into country operational use, if you like, in the event of a pandemic. And if I may, I mean, I've been out, we work closely with my equivalent agency, KDCA in South Korea, and I've looked with them, with Dr. G, the director, quite carefully at how they use their laboratories. And a lot of this is about turning facilities that are there and having them available directly for government for intervention.
Thank you. And thank you for that additional insight around the decision-making to the closure of the Rosalind Franklin. Can I then finally, before the lunch, just deal with another topic under the heading of preparedness, please? Could I ask to be displayed, please, I&Q 535912. 535912. Thank you. This is an independent SAGE paper. I hope you've had an opportunity to consider this as part of the material, Professor Harries. Can we move into the fourth page, please? Thank you. And we can see under the heading the UK experience, it detailed, they expressed the view that the UK could have broken transmission chains if we'd mobilised local test and trace capacity during February and early March, with proper incentives for isolating households and community facilities provided for less severe cases. Can I ask, do you agree with the conclusions of Independent SAGE that TTI could have been effectively mobilised at this stage, despite the barriers, including lack of infrastructure and speed of widespread seeding of infection?
I think it's important to realise that local test and tracing systems were mobilised, and in fact they never paused. I think there are statements I've seen in different documents saying, why was community testing stopped? Why was something stopped? In actual fact, where it was possible to keep going, it tended to be focused. So Public Health England teams then would, for example, look at backward contact tracing on, different outbreaks. So I think that's an important point. I think it goes back to my comment I've just made, which is whilst I don't agree with the detail here, I do think there is an issue which the UK, plus many, many other countries, did not have a capacity sitting ready for the eventuality and a mindset that said, we can stop this. And for me, in my current role, that is actually the really important element to go forward, because in doing that, it encourages us all, I think, to look at all of the opportunities and set out on a long-term basis how we can manage these in the future. There are some particular issues here around, for example, isolating households, that we may come on to, and I'm sure about how we support households. And I think there is a much wider issue, which is really important, around where were those local hotspots, why were they the hotspots, and who was most affected, that, again, we need to address in peacetime in a much more transparent way than perhaps normally occurs for our health service. We need resilient communities as well as all of the things that we're discussing.
And so can I ask you, in terms of identifying that we need to identify the hotspots, why they're there, and do that work in peacetime, has that reflective work happened in UKHSA?
Yes, definitely. So, I mean, identifying hotspots can be a surveillance issue, which I'm happy to pick up separately. But what I'm referring to is there are two things that I did when I first came in, and this does pick up my background as a Director of Public Health. One thing was about starting the Future of Health Protections work programme, which has actually yielded some really positive results recently. It was the first thing I kicked off, and it's taken 3 years to get to the answers, but it is co-produced with local authorities, with ASDPH, with environmental health officers. So that's a really important piece of work. But what I'm really referring to is actually we know where the communities are who are going to be least confident to come forward, who are least going to trust us, who are also going to have the worst underlying health conditions. And those underlying health conditions and the disparities in them are there now. So the real question is, why are we not addressing them now, so that when the next pandemic starts off, we're on at least on an equal platform? And the work I have done there, and probably as I'm leaving, I'm doing my legacy point, which is actually I think we are the first health protection agency in the world to have a health equity in health protection strategy. So that's an overarching strategy to really push this out into the domain of routine work. And then we've just done our first report, which highlights the different rates of infectious diseases, admissions to hospitals. And you can see this by deprivation. Much of this is vaccine preventable disease that we can amend. But we need to work with communities on the longer term, not just when a pandemic hits.
Thank you. My lady, is that a convenient moment?
Certainly. I'm sorry we couldn't finish you before lunch. I know how busy you must be. If nothing else, tidying your desk. I return at 2:00.
All rise.